these have been excellent topics, the ones we've listened before. Thank you. Now we're going to address proximal humerus fractures, and we're going to talk about a bit more about what is controversial in decision-making procedure. So we know that proximal humerus fractures are common amongst the elderly population, and treatment options will depend on a lot of factors: the fracture, the type of fracture, displacement, bone quality, patient, which is very important, its age, activities, expectations, and the surgeon, of course, his expertise and process of thought. So for many variables, we have a lot of options for these patients. Now we know that this is an age-related injury. Very few patients are young patients because of high energy fractures, but over 70% of patients with proximal humerus fractures are elderly patients with low energy fractures. And the thing about these elderly patients is that as we have increased life expectancy, we have a much wider range of different types of patients. Not all these patients are the same, and they don't have the same expectations or limitations. So we can see these are two mirror-like images. It's exactly the same fracture, a varus displaced fracture, but one patient is 61 years old, and the other one is 94 years old. So you can see they are at the extremes of this curve, at the extremes of the age-related injury, and they probably will need different treatment. So we have to be very selective on what we do. So treatment options will be basically divided in two types, either non-operative, which are most of the cases, or operative. And if it's operative, either reconstruction procedures or arthroplasty. So the goal of this presentation right now is to review different settings and current trends for proximal humerus fractures in elderly patients. As we have seen for many variables, there are many options. So the first thing we ask ourselves is, who needs surgery? Do we do non-operative or operative surgery? Well, there are a lot of factors that we have to take into account for this. So we know that most patients will succeed with non-operative surgery. So a lot of papers show that between 72 and 92% of proximal humerus fractures are treated successfully without surgery. They do not need surgery. And what are the factors that influence our decision for non-surgical treatment? For a start, fracture type and degree of displacement. Most of the fractures we see are either non-displaced or minimally displaced or have acceptable displacement, and that is why they do not need surgery. And minimally displacement or acceptable displacement usually goes around these terms, that is less than head-to-shaft displacement of 50%, varus or varus deviation 20 degrees, and 5 millimeter graded tuberosity displacement. Now, these patients can be successfully treated without surgery. Even more, if they have some minimal displacement or acceptable displacement, they will do fairly well. Now, the other factor, which is the most important one today, is the patient itself, its age, activities, and expectations. So we have literature that says that no matter what type of fracture, if it's displaced, even if the patient is elderly, they might not benefit from any surgical procedure. So different published papers are showing that there is no significant difference for functional outcomes between operative and non-operative treatment. Of course, there is a high risk for reoperation in the operative versus non-operative treatment. And some other published literature highly recommends not do any surgery for displaced fractures in elderly patients. Now, this is a bit controversial for us, and there may be some selection bias for this patient. But if we get patients like this as orthopedic surgeons, a 78-year-old male who is an independent lifestyle patient, lives on his own, and is not in a nursing home and needs his arm, it's very difficult for us as orthopedic surgeons to just let him go by. So evidence-based medicine has shown us that he might not need surgery, but the question we have to ask ourselves as surgeons is, can he benefit from surgery? Can we make him better than he is right now? So there are some randomized controlled trials talking about surgery versus non-operative treatment. This is internal fixation versus non-operative treatment in elderly patients. And there seems to be an advantage in functional outcome and quality of life favoring lock-in plate as compared to non-operative treatment, but still complication rate and reoperation rate is high for internal fixation. So we have to take that into account. Now, what about hemiarthroplasty? Hemiarthroplasty versus non-operative treatment in elderly patients. Well, there is some advantage, especially in the quality of life for these patients, in terms of pain relief. Pain relief, but not function. Most of the patients with hemiarthroplasty would not get better function as non-operative treatment, but they will surely have less pain. Reverse shoulder arthroplasty, which is now very common to use, compared to non-operative treatment, we might not think it's as beneficial as we see. This paper, randomized controlled trial, has seen no significant benefit clinically or functionally, at least in the short-term follow-up at 12 months. But there is a trend towards higher pain score in the non-operative for surgery versus non-operative patients. So not only do we have to assess fracture type and patient, age, activity, and expectations, but our surgeon experience is very important because a lot of times we can tell a patient he might do well without surgery or with surgery, and they ask ourselves, what would we do for them? So this is an 87-year-old patient with a displaced humeral shaft neck fracture. And so we have to evaluate this patient very well. So she was independent, she was very healthy and a very active patient. So we went along and did ORIF for this patient. And fortunately, she did very well. She did not fall into that 30% of patients with complications. For her, this probably is a very successful treatment. So we have to balance out for non-operative treatment, evidence-based medicine for sure, but also our experience-based medicine, and most importantly, patient needs, and talk about potential benefits and complications rate, because as we see, not all the elderly patients are the same and have the same needs. So once we ruled out non-operative treatment, which will be most of our patients, we only have left operative treatment. What are we going to do with those patients that we say we do surgery for them? We have either reconstruction techniques, the ones anybody likes most, percutaneous spinning, intramedullary nails, plate fixation, or the replacement techniques, which are hemiarthroplasty and reverse shoulder arthroplasty. So how do I choose between one or the other? The first question I ask myself is the humeral head salvageable? Is it worthwhile fixing, and can it be fixed? So if they can be fixed and they can be salvaged, I prefer reconstruction. Now, how do I know if the humeral head is salvageable? Well, we don't know for sure because all patients are variable, but we have some criteria or some predictors for ischemia, of course, and the most popular one is that published by Hertel in 2004, where if there is an anatomic neck displaced fracture or metaphyseal extension of less than 8 millimeters, medial hinge disruption over 2 millimeters, or humeral head split, if we add these factors, there is a high prediction for ischemia. Now, 4 years later, Hertel used the same population, and he said that not all his patients with ischemia necessarily went to necrosis, because there may be revascularization or creeping substitution possible if we get good fixation. So sometimes if we tweak, we can get a good fixation, we can go ahead and try for it depending on the patient. So this is a 67-year-old patient with osteopenic bone, 3-part fracture, but we see that the ischemia factors are in favor of us. We have a good metaphyseal extension, and we think we can get a good fixation, simplify this fracture and do it, then this is my preferred choice. Now this other patient, 72-year-old patient, has a similar fracture, but if we see at the 2-dimensional CT scan, we have this eggshell remaining of the humeral head. So this is what I think is not a fixable fracture. On the other hand, this is very similar fracture, 68 years old, but if we see we have some bone stock left, and it seems to be good quality bones so for these patients, if they have this varus split fracture, which is not very good tolerated, if the patient is active, I do prefer to disimpact them, re-impact them in a better position, put the plate, and then do suture augmentation for the cuff and get better alignment and better function. Now, if we do plate fixation, we always have to remember that we still have a high complication rate, approximately 30%. And the most important one, or the most common one, is the collapse into varus. How do we avoid collapse into varus? If we can, we have to give medial column stability with all these factors or tips that we can do for these patients, but this is not what we're going to talk about today. So if the humeral head is not salvageable, and I think the fracture is not fixable, and if it's an elderly patient, we go for replacement. Of course, if it is a young and active patient, we do our best for reconstruction. But if not, we go for replacement. And we have two options, hemiarthroplasty and reverse shoulder arthroplasty. Now, the current trend today is that hemiarthroplasty is being less and less used in compared to reverse shoulder arthroplasty. Reverse shoulder arthroplasty is really growing, especially during these last years. Now, why are we not using hemiarthroplasty so much? Well, because hemiarthroplasty, the technique is it's not only just to take the head out and use the hemiarthroplasty as a spacer. If we don't get the tuberosity fixation right, then this patient will indirectly have no rotator cuff, and as the deltoid tractions, the head will just rise, it'll impact, and we will have like an orthopedic rotator cuff deficiency. The humeral head is not stable. If we get the fixation like we want it to be, we will have a stable fulcrum of motion, and that is how the patient will do well. But hemiarthroplasty is challenging because we have to get the humeral head size right, the orientation right, the depth of the stem right, and then we also have to get a stable fixation of the tuberosities, and then we have to wait for them to heal. So it ends up being a complex surgery, and it's not very, very predictable. So unless we get them like this, we get them to heal in a very concentric manner with stable fulcrum of motion, patients will actually do very well. But approximately 50% of the patients with hemiarthroplasty can only raise their arm to 90 degrees. So reverse shoulder arthroplasty, this is our current trend. Why? Because it may get away without tuberosity healing. It has a more predictable outcome than hemiarthroplasty because it is a semi-constrained type of prosthesis. So the center, the fulcrum of rotation will be stable. We do the tuberosity fixation anyway because the patient will get better rotation probably if we do. But there are a lot of studies now that have shown better functional results and less revision rate with reverse shoulder arthroplasty than hemiarthroplasty for proximal humerus fractures in elderly patients. So this is our choice for reverse shoulder arthroplasty in these patients, elderly patients, where we see that the tuberosities are not fixable or they are comminuted. So it's exactly the same procedure as the hemiarthroplasty, but we have to address the glenoid, of course, and put our glenosphere right, have good orientation, and then the same. For the stem part, we have to get the height right adequately so we can fix the tuberosities where we want, and we can get the tensile load of the deltoid correctly. So it has its issues as well, but the functional outcome is more predictable, especially for elevation in these patients. So for final considerations, as there's increased life expectancy and this range of patients are very different one from the other, we have to individualize our treatment options. We have to analyze very well what is the chronologic age versus the physiologic age of these patients, what are their expectations, and if we choose to do surgery for them, try to reduce as many unnecessary risks as we can to make it a one-time procedure. Thank you very much for your attention.